Hello guys, welcome to our channel. Today we are going to discuss about the pediatrics rapid revision. In this two parts we are going to discuss. First part will be consisting of the growth and development and also nutrition neonatology. Okay, and the part two will be consisting of the all the systemic pediatrics from the cardiology, neurology, all etc. will be considered in the part two. Okay, so let's discuss the part one. In this part one we are going to cover the most important topics. So those who are new to this channel, please do subscribe and share with your friends. So let's start the discussion, guys. First, we are going to discuss about the developmental milestones. At least one question will be asked in this section. From this section, it could be gross motor, fine motor, or anything. But we are going to get the at least 1 to 2 questions will be compulsory from this chapter. So gross motor milestones. What is the gross motor milestones? Like standing, sitting, whichever you are using the long bones, that all considered as the gross motor milestones. So, but the gross motor milestones will be using the cephalocaudal pathway. That means they are coming from the head to toe. Okay, so the pattern will be cephalocaudal pattern. So how that? Let's see. At the 3 months, the patient will be having the neck holding. That means it started from the neck holding only. And next, at the 4 months, rollover, and 6 months, sit without support, especially in the tripod position. Like this, the baby will be in the tripod position. And from you can see the 3 months, the baby started the neck holding, and then by the 6 months, baby already sitting position. Right? This is what the cephalocaudal pathway. And next 8 months sit without support, and 10 months stand with support, 12 months stand without support, 15 months walk without support, 18 months running, 2 years climbing, and 3 years climbing, and also rides the tricycle. 3 tricycle, and 4 years climbing with one foot and also downstairs and hopping. Okay, and also hopping. This is the gross motor. How can you remember easily? Just remember the all are going to be the important numbers only. 3 months neck holding, 6 months sit without support, 8 months sit without support, and 10 months stand with support, 12 months stand without support, 15 months walk without support, 18 months already running, 2 years climbing upstairs, and 3 years climbing upstairs with the one foot and also rides the tricycle, and fourth year climbing one step downstairs and also the hopping. Next, fine motor skills. Fine motor at 4 years, the baby will be having the bidextrous grasp. Means with using the both hands, the baby is going to grasp any object. At 6 months, unidextrous grasp. And how the unidextrous is going to start from the ulnar aspect. Okay, if this is the palmar, right, in the palmar, the first the baby is going to use the ulnar aspect, then radial. Okay, first is the ulnar. Next 8 months is going to be also unidextrous, but this is the radial palmar grasp. And from when it is coming to the radial side, it's already a mature palmar grasp. 9 months immature pincer grasp. Pincer means using the fingers, okay, from the sides of the finger, that is the pincer grasp. And 12 months mature pincer grasp, that the baby can hold with properly with the fingers. Next 15 months make the 2 cubes, 18 months 4 cubes, 2 years 6 cubes, 3 years 9 cubes. It's like a table only. 2 3s are 6, 3 3s are 9, right? 18 months 4 cubes, 15 months 2 cubes. This is also very important. And 2 years draws the line. Okay, how many ends? 2 ends. So 2 years, 2 1 line, that you have to remember. 4 years cross. Remember this. 4 years cross. 4 ends. 4.5 years draws the square. Not so important, but just remember. And 5 years triangle. 6 years diamond. These are the important points that you have to remember. And 3 years circle. Next, language milestones. In the language, 3 months cooling, 6 months monosyllables, 9 months bisyllables, 1 year 1 to 2 words, 18 months 8 to 10 words, 2 years sentences, 3 years recognizes and tells the name, age, gender. Three words they are going to tell, right? Name, age, gender. 4 years already tells the story and the rhythms. Social milestones: 2 months social smile, 3 months regarded as a mother as an important person, and 6 months stranger anxiety. This question is also asked. 9 months bye bye and peekaboo, and 1 year plays the small play game, ball game, and 2.5 to 3 years it is going to be the parallel play, non-interactive with the group, whereas 4 years the baby will be playing with the group play. Remember, 4 years, 4 people are playing together. That is a parallel play. Red flags. Why we have to consider this red flags? Because this is tell us the baby might be going into the delay of the development. The developmental delay will be showing from the red flags. What is the upper limit for this? If the baby cannot speak or cannot make any proper sounds until 6 months, not even like a cuckoo, mama, these all sounds, that is considered as a red flag for the vocalization. For the sitting, 10 months, because we already seen 6 and 8 months she should be already sitting for the with and without support, but if it is not, it is considered as a red flag. Same as the standing, by the 15 months baby has to stand without support, by walking also by 18 months, and single words by the 18 months. If any of these are not seen, these are considered as a red flags. Next, coming to the growth charts, these are the WHO growth charts where we are going to use pink for the girls and the blue for the boys. What we are going to see, we are going to check whether this is particularly the baby is having the proper growth or not. Severe acute malnutrition, SAM babies. These babies are considered as a severe malnutrition. For example, if you see the baby weight for height or weight for length less than 3 standard deviation, or the presence of the visible severe wasting, presence of the bipedal edema from the nutritional origin, or the mid upper arm circumferences of the less than 11.5 centimeters. If any of this one present also, we have to consider that the baby is going into the severe acute malnutrition. And what is the treatment protocol? We are going to consider as a two phases. One is the stabilization phase, another one is the rehabilitation phase. The stabilization phase will be the first 1 week, and remaining 2 to 6 weeks will be considered for the rehabilitation. Okay, this is how we are going to check. In this, we are going to consider that these are the complications such as hypoglycemia, hypothermia, dehydration, electrolytes, infections, micronutrient deficiency, and cautious feeding, catch-up growth, sensory stimulation, and preparing for the follow-up we are going to see. And remember, in the stabilization, we are not going to give the iron, and in the rehabilitation only we are going to give the iron for these patients. Next, what is the criteria before you have to discharge? There should be no edema for the 2 weeks, and weight should be increased or it should be more than -2 standard deviation, and moderate. This has to be reached mid upper arm circumferences 12.5 centimeters, that it has to be reached. Next, kwashiorkor and the marasmus. Kwashiorkor baby, the baby will be having this belly fat. That means the baby is having actually edema due to ascites. And marasmus patient, no belly, no edema will be seen in this patient. Complete severe wasting will be seen. And if I has to ask which is the more severe, you guys always has to remember the kwashiorkor is more severe than the marasmus. Why? Because this is due to protein deficiency, and marasmus baby is the protein and calories deficiency. And kwashiorkor is 6 months, and same as this is also 6 months or 1 year. Subcutaneous fat is reserved and edema is present, whereas marasmus, no subcutaneous fat, no edema will be seen. Next, enlarged fat, lethargic patients, see poor appetite and more severe condition. Marasmus will be no fatty liver. There will be alert and irritable, severe muscle wasting, voracious appetite, and the less severe condition. And some of the childhood infections that you have to remember: measles first. Measles belongs to the Paramaxoviridae, and the incubation period is on an average 8 to 12 days, and respiratory droplets is the most common cause, and 4 days before the rash and 5 days after the rash, the measles is a very infective period to other children, and they are considered as three phases. One is the prodromal, another one is the exanthem, and the exanthematous. These three phases, for example, prodromal is the 3 C's, guys: cough, proesa, and conjunctivitis. And example inside the coplic spots. You can see this is how it is going to see coplic spots on the buccal mucosa of the especially second lower molar teeth. Exanthematous, this is exanthematous means the on the skin there will be maculopapular rash which starts from the ear and spreads all the downwards. And next, we are going to consider the most common complication is the otitis media, but the severe one is the pneumonia. And the chronic complication is the SSPEs. This question is also asked. And the diagnosis IgG positive in the CSF. Treatment will be supportive and vitamin A supplementation we are going to give. And the prevention will be MMR vaccine. And next we have the rubella condition. In the rubella, we are having the Togaviridae family, and this is also due to respiratory droplets 5 days before and 6 days after the rash is the infective period. And the rash will be starting from the maculopapular rash from the face to the trunk and the limbs. Okay, it's like a cephalocaudal pattern. And there will be four shimmer spots on the hard palate. Here you can see this is the four shimmer spots, and also lymphadenopathy. The main differences will be no lymphadenopathy in the measles. There will be lymphadenopathy in this patients of the rubella condition. All right. Next, the most common complication will be thrombocytopenia and also encephalitis. MR vaccine is the prevention. Again, the patient is going to have the supportive treatment only. And varicella zoster, this is the herpes zoster virus, and it is also due to droplets 24 hours before and also till the rash is going to lay off. Until then the varicella is infected. Same, the patient will be having the fever, rash, and but the rash is the dew drop in the rose petal appearances. Okay, the vesicles polymorphic, all the rash will be seen in this patient. Okay, and on the Tay-Sachs sphere we are going to see this kind of the lesions because this is a viral condition and also IgM positive. Again, supportive treatment acyclovir if this is a severe, and avoid the aspirin. Why we should avoid the aspirin? Because it can trigger the Rice syndrome. Varicella vaccine, live vaccine is given for this patient. Most common complication will be meningoencephalitis, that is a commonly seen in this condition. Okay, this is what is this condition, guys? This is known as a fifth disease due to parvovirus, right? Slapped cheek appearances. Next, what is this condition? Sixth disease. This is the roseola infantum, and these spots are the Nagayama spots. Okay, these are the Nagayama spots. Next, congenital infections. Most importantly, rubella is the most important, and the triad is it is going to cause the hearing loss, cataracts, and the heart disease. In the heart disease, the most common will be the patent ductus arteriosus. Another other features will be salt and pepper retinopathy, blueberry muffin lesions, purpuric spots, which is non-blanching and the dome shaped. CMV, in the CMV, we are going to see the chorioretinitis and microcephaly and intracranial calcification. Okay, this is the most common overall all the infections. And congenital toxoplasmosis. In the congenital toxoplasmosis, we have the highest rate of the transmission in the third trimester. This is the first trimester, guys. This is also first trimester. Okay, but in the third trimester the most common is the toxoplasmosis. How can you remember? Third toxo, both are TT, and the triad will be chorioretinitis, intracranial calcification, and the hydrocephalus. Varicella syndrome, this is going to intrauterine transmission, cerebral atrophy, microcephaly, limb hypoplasia, and cicatricea because the irregular scarring and the burn scars that will be seen on the skin. Syphilis also, if it is a early onset, less than 2 years, which will be seen as a rhinitis and the snuffles or the pemphigus syphiliticus and metaphysis of the osteochondritis and the parasitis. And in the late onset, the patient will be having the Hutchinson triad. In the Hutchinson triad, also again hearing loss, Hutchinson teeth. Hutchinson teeth will be like looking like this. Okay, this is how Hutchinson teeth. And interstitial keratitis, mulberry molars and deformed nose, saddle nose, roguites, which is the fissure and the mouth nose, Saberstein, the bowing of the tibia, and the Clutton joints in the bilateral knee effusion. Zika virus, most commonly it is going to cause the skull manifestations, eyes, coloboma, and the sensorineural hearing loss on the limb. And especially here you are going to see the microcephaly. Parvovirus B19, it is going to cause a severe anemia, which will cause the cardiac failure and the non-immune hydrocephalus. Next, coming to the neonatal resuscitation. Okay, this is also very important topic. In the neonatal resuscitation, we have to check first 4 birth questions that we have to see if the baby is a dumb, baby tone is present, or the baby cry is present. If anything is non-absent, not present, we have to immediately move for the next step. That is, check the temperature, airway, and the circulation. If everything is normal, but still the baby is not crying, then we have to check the heart rate and the respiratory rate. If the heart rate is less than 100, we have to start the positive pressure ventilation. If still it is not improving, then we have to check again. If it is less than 60, go for the chest compression with ventilation. Even if it is not improving, less than 60 heart rate, then we have to start the adrenaline. How much adrenaline? 0.2 ml via intra-umbilical route. Via intra-umbilical route. Then we have to volume expansion, which has to be done immediately. Within all this has to be done in the first 2 minutes only. Okay. Initial assessment is the baby is term, amniotic fluid is clear, any risk factors, maternal or the fetal, and the umbilical cord management. Delayed cording we do at least 1 minute. Why? Because the temperature, breathing, and airway positioning that has to be improved initial steppings, and also if it is not improved, sorry, the delayed cord coupling which will be done to decrease the chances of the anemia. Okay, the best reason is that decrease the chances of the anemia. And next initial steps we have to take in the patients of the neonatal resuscitation is the check the temperature, keep under the warmer. Breathing should be done because rubbing over the back and the flicking the soles, which will stimulate the breathing. And airway positioning, sniffing position is which we most commonly used in the especially in the neonatal resuscitation positions. And heart rate assessment. If the baby is no cry after the birth, significant hypoxia, decreased 100, then what we have to do? If it is more than 100, poor breathing, oxygen should be given. If it is less than 100, no breathing, then start the positive pressure ventilation and the bag and mask ventilation should be done. And remember, bag and mask ventilation is contraindicated in the congenital diaphragmatic hernia. Jaundice patient, physiological jaundice and the pathological jaundice. Physiological jaundice is the normal, pathological jaundice is the abnormal. Why? Because physiological jaundice is the after 24 hours, whereas pathological is within the 24 hours we are seeing in this patient. This is the conjugated type, this is the unconjugated type. And when the physiological jaundice is, the levels of the bilirubin will be mild, whereas pathological is more than 15 also seen. Palms and soles are the spares, here the palms and soles is involved. And physiological jaundice will be disappear by its own, usually like within the 2 weeks. And it is more than 2 weeks, it needs the phototherapy and also exchange the transfusion. And most common severe complication will be kernicterus, which will be seen with the pathological jaundice. Neonatal conditions such as the respiratory distress syndrome, transient tachypnea, and the meconium aspiration. The RDS will be seen in the preterms, transient tachypnea will be seen in the term babies, and the meconium is seen in the post-term babies. Okay, these are the first differences. And in the respiratory distress syndrome, the main problem is the surfactant is deficient. Okay, surfactant is deficient. So that's why the baby can't breathe properly. So you are going to see the whiteout lung, complete whiteout lung, and also air bronchogram sign on the patient X-ray. Whereas transient tachypnea is a wet lung, means inside the fluid is still present. The fluid is not yet gone. That's why you are going to see the fluid in the intralobar fissure, where you are going to these kind of the lesion. This is the fissure that you are going to see, and also pleural effusion, okay, which will be commonly seen. Meconium aspiration. The meconium is aspirated by the postterm babies, where you are going to see the patching infiltrates and the hyperinflated lungs you are going to see. And all three are going to be the supportive grade. First, you have to submit the oxygen therapy for the baby, and if needed, the outside the artificial surfactant can be given for this baby. And again, here also it is going to be improved within the 48 hours by the oxygen itself. And in the severe conditions of the meconium aspiration, we are going to give the nitric oxide as a treatment. Next important one is the ABGAR scoring. Here you are going to see the first activity, pulse, grimace, appearances, and the respiratory effort. Activity, if it is 0, absent tone, some flexion 1 point, good flexion 2 points. Heart rate less than 100 will be 1 and more than 100 will be 2, and if it is nothing, 0. Grimace means just a mild irritability is seen in the patients. If it is no response 0, grimace is present, mild irritability is seen 1 point, and complete cry, cough, sneezing, that will be 2. Appearances, complete blue. This is a cyanotic baby. Complete one means the body is pink but the extremities is blue, also known as the acrocyanosis. 2 will be for the pink all over the body. Respiratory effort, if it is 0 means nil, and irregular and slow breathing 1, and complete good cry, that is 2. This is the ABGAR score done in the first 1 minute, 5 minutes and the 10 minutes. Alright, next, breastfeeding start as soon as possible for the patients those who are normal delivery, less than 4 hours for the cesarean section. Exclusive first, the breastfeeding should be done for the first 6 months and complementary feeding for the until 2 years. Colostrum, this is the first milk which will be rich in the fat and also immunoglobulins such as the IgA, lactose, and also fatty acids like a dopoxo acids will be present in this baby. The amino acids such as the cysteine and taurine for the axonal growth, and these fatty acids dopa-oxy, that is important for the myelination. Absolute contraindications such as the active tuberculosis without medicine, and also radiation, chemotherapy, galactosemia, and the lactose intolerance. These are some of the important points that you have to revise for the examination. And next part will be consisting of the systemic pediatrics. Until then, stay tuned. And those who are new to this channel, please do subscribe and share with your friends.